All right. Next up, we have Greg Appleman with his concept, Appleman Airway. Come on up. And when we have our question and answer, if you don't mind, we'll bring a microphone around to you guys too. All right, clicker's all yours.
All right, thanks. Good morning, everybody. My name is Greg Appleman. I'm one of the anesthesiologists at UCMC over here. And today we're going to be talking about my device, the Appleman Airway. So who am I? Why should you listen to what I have to say? I've been practicing anesthesiology for about 17 years now. The problem we're going to talk about, I see all the time. It's very significant. I've done at least 25,000 anesthetics, and that's probably conservative. I came from Georgetown University, got here to Cincinnati, where it's a lot easier to live. So we're going to talk today about anesthesia and endoscopy. And many of you in the room have probably been through an endoscopy procedure, but if not, that's the thing they're going to stick down your throat, into your stomach, and look around. Most people, when they hear about this, they say, put me to sleep. So we're going to talk about what happens when you get put to sleep. This is our anesthesiologist. He checks out you or his patient. He decides everything looks good, and he's going to very safely make a plan to get you off to sleep. He hooks you up to the propofol, and we start giving you medicine to make you go to sleep so that they can put that horrible long thing in your mouth. We look at your vital signs. This is our most important thing. This is how we know you're safe. We watch your breathing. We watch your oxygen levels. All this stuff tells us that you're safe during this procedure. Now, what's about to happen next is something that happens very, very commonly during these procedures, at least 50% of the time, and it poses a very significant risk to your safety, which is why we're here with you in this procedure. This is airway obstruction. Airway obstruction happens. On the left, you can see a nice open airway. The tongue is not blocking the airway, and there's free flow of ventilation to keep you breathing and oxygenating your blood. On the right, you can see that the airway is obstructed. The back of the tongue has fallen over the airway, and it's pinching closed, making it very hard for you to breathe. When this happens, you are not safe. What happens in the endoscopy procedure room is this. Our anesthesiologist sees that your oxygen saturation is now dropped. You're not safe anymore. The alarms start going off. He tells the proceduralist to stop what he's doing. Pull out your endoscope because I have to get this patient's oxygen levels back up. So now he's performing a maneuver called a jaw lift, which pulls your tongue up out of the way and lets you breathe again. This is going to bring your oxygen level back up and prevent something bad from happening to you. We figure at least half of the 8 million endoscopies have this airway obstruction occurring, and it may be more than that. And out of those 4 million, probably about 500,000 are necessitating pulling out the endoscope, which then leads to a delay in the procedure and a delay in the whole day of endoscopies. This is an oral airway. An oral airway is a device that we use to prevent airway obstruction. It's designed to go in your mouth. It pushes your tongue out of the way, and it prevents that from blocking the flow of ventilation. Problem with endoscopy is they want to put a big camera in the spot that we want to put an airway. Obviously, can't be doing both. There is no device available to help us during this procedure with airway obstruction. We're forced to do those maneuvers that you saw where we crank up on your jaw or we pull your chin up to pull your tongue out of the way. And that can be very time consuming and arduous for us. And it can also not always be effective enough to get through the procedure safely. The airway that I've designed is designed specifically to work during upper endoscopy. It has a bite block built into it and a means to replace the current things that go in the mouth to provide the exposure that the endoscopist needs. It's designed to relieve the airway obstruction that we talked about. It's also got features to improve gas exchange, which allows us to better deliver oxygen to you and sample the breaths that you breathe out so that we know you're breathing adequately. This, in turn, will lead to safer and more efficient endoscopy procedures. The anesthesia device market is very, very robust. We spend a lot of money in the hospital. $13.7 billion in anesthesia and respiratory devices, and the market that we're looking at is this $2 billion in respiratory disposable devices. This is not a problem that's going away. It's getting worse. Every year of my practice, we see more and more patients have significant and severe airway obstruction. And this is directly correlative to the obesity epidemic, which also relates to the sleep apnea problem. And these two concerns both make this situation worse and shows up every single day. So I need an EIR. What I've done so far is a lot of research. I've done focus groups with all the anesthesia providers that I know. I've done design, drawings, and I have a provisional patent in place. The next step for me is to get a prototype down so that I can get this out to the people I know and start some clinical trials. And I have a network of people that I can use to do this. And obviously, as we get through the whole procedure here and we get this to market, the goal is to get this in every single endoscopy center, every single hospital all around the country. And this is a gigantic market that's essentially untouched. And here you see our happy physician. This is our gastroenterologist who's happy that his procedure did not get delayed. And this is our happy patient on the right who knows nothing about the airway obstruction that happened while he was sleeping, but he was safe anyway. Thanks very much. If anybody has any questions, I'm happy to answer.